What I want to do is this morning, as Mark said, what we'd like to do is discuss opportunities for building a risk identification system and some of the insights we've learned within the OMOP experiment that seems to suggest that there are some promising opportunities for us to have some practical recommendations for which methods to apply to which databases and how well they'll work. And the reason why Paul spent some time going through those study designs is because as we've been reviewing the results, we've been trying to struggle with going back to first principles, thinking about those study designs, and trying to better understand why and how the results that we're observing have come out. And ultimately, I think all of us, we share a common goal, which is we'd like to build a risk identification system. We'd all like to have a system that could help us better identify and evaluate the risks of medical products. The only challenge that's in front of us is we need to make some decisions. Which data do we put into such a system? Which methods do we apply to those data? And how much evidence can we reliably infer from such a system? So I think many of us went into a lot of this endeavor several years ago kind of with a favorite tool in mind. And so I'm just curious from the audience here, right now, before we get started, if you all had to build a risk identification, as some of you in the room actually have to do, if you had to do that, and given Paul's insights about the study designs, I'm just curious by a raising your hands, how many people would choose the new user cohort design? Raise your hands up high. I want you to be confident and with conviction in your selection. Okay, about half the room or so. Okay. How many people would choose a case control design as their preferred study approach? Ralph, a couple others. Ralph, you're in the minority there. Okay, how about the self-controlled case series design? Oh, we got two hands from Soledad, so she's got some conviction there. Okay. Okay, so it looks like if this was a democracy, we'd be moving forward with a new user oh, actually, I should say, who thinks that the solution is not a cohort design, not a case control design, and not a self-controlled case series design? Oh, we got a couple other hands. Okay, so there's other too. Okay. Well, so we kind of went in with the same approach, try to understand, and rather than us making an assertion of picking a design, instead what we wanted to do was test all of these designs and start to evaluate their performance. But as you voted, so too did our OMOP group. We kind of voted as a starting point and said, well, cohort seems reasonable. And we could base that on a lot of the thoughtful work that's already out there in the published literature. Many of you are probably familiar with Sebastian Schneeweiss's work. He has a nice, thoughtful perspective piece in the Pharmacoepidemiology and Drug Safety that talks about recommendations for how we should build a safety signal evaluation tool, which effectively provides some first principles for why a new user cohort design makes sense. And then I'd recommend this paper to anybody who's interested in that expert assessment there. So again, so majority rules, maybe you all just are influenced by Sebastian, maybe Sebastian's influenced by you, but another good piece of evidence to think about why a cohort design makes sense. Now, Mark introduced Eddie, the survey that we conducted, and while the survey was anonymous, I'm going to suspect that many of you in the room might have been our respondents for this, and we were really excited by the level of participation we got on this survey. We had over 136 participants in our online survey, most of which had medical degrees or PhDs in epidemiology, or were leading experts doing principal investigator work on these study designs. And again, the question in that survey was basically posed a hypothetical. I'm going to give you a drug outcome pair and ask you what study design would you choose for that particular drug outcome association. And altogether, we were able to collect results for over 720 drug outcome scenarios for which the experts were able to make choices about whether they would choose a cohort design, case control design, self-control design. And this allowed us to be able to evaluate how consistent those decisions were made across our expert community. And so I'll orient you. For those of you who were at the symposium last year and remember thinking, geez, these OMOP guys keep making eyesores to stare at. Well, there's going to be a lot of those today, so I'm going to apologize in advance. Our solution to that problem, rather than making clearer slides, was by bigger screens. So we listened to the feedback there. So on this graph here, what I'm trying to show you is in the columns, I'm representing the different outcomes of interest. So here you have acute liver injury, acute myocardial infarction, acute renal failure, and GI bleed. And each of the rows here represent the drugs or drug classes that we asked the experts in the EDDI survey about. So ACE inhibitors, amphotericin B, antibiotics, antiepileptics, bisphosphonates, tricyclic antidepressants, typical antipsychotics. And so we had a large cohort of experts ask the same exact question. If you were told you need to design a study for ACE inhibitors and GI bleed, what would you do? And so here are the results. On the x-axis, I'm showing you the different study designs, just as we just raised our hand. And similar to what we just saw, the majority of people selected a new user cohort design. However, there was a good handful of folks who did join Ralph in thinking about a case control design. And there was also a handful of folks who thought self-controlled designs might work. And there were some folks that thinking there's some other solution out there that might work. Now, I don't expect to go through the entire graph here, but one thing you can notice is cohort design seemed to be the majority rules across all of these drug outcome pairs. But a fascinating insight we got here is across our research community, there was a lot of people who thought lots of different designs could be useful for the same exact question. And I think that's a particularly important finding for us as we think about developing shared practices across our research community. Hopefully we can get to the point that we can more effectively harmonize on best practices and have a better understanding of why we're making choices and how well those will perform. So Paul mentioned this. We looked at that Smith et al. Paper that studied isoniazid in acute liver injury. And our approximate example of that study that we conducted within OMOP, using that new user cohort design, we applied it to the Market Scan Medicare database. Pretty standard new user cohort design, effectively a 180-day washout. We created a referent group of people who had the indication, so they had tuberculosis, but they were not exposed to the target drug. We used the duration of exposure as the time at risk, and we did propensity scoring as an adjustment strategy, whereby the covariates we put into our propensity score were age, sex, year, Charlson score, the number of visits, and then we created individual covariates for all different drugs, all different conditions, all different procedures, and put that into a large logistic regression to estimate a propensity score, to adjust the groups, and as Paul showed, we got an estimate that's pretty close to the published literature. So, well, a show of hands, does everyone feel like that study design seems pretty reasonable as a starting point? Wow, only half the people think that's reasonable. Okay. Well, we look forward to hearing from the other half of you as we move forward. I'll say I thought it was kind of reasonable. I mean, it seems like a pretty reasonable result and a reasonable design as a starting point. Again, that study was designed for isoniazid in acute liver injury. The thought experiment that I'm going to walk you through for the rest of the morning is what would happen if we apply that tool in the context of a risk identification system. Okay, so I'm not just asking the question, what about isoniazid in acute liver injury, but we're trying to answer the question, can this tool be systematically applied for any given drug and the specific 4 outcomes that we are focused on. And so the thought experiment would be, what if we could take the design from Smith et al. And apply that consistently across all of our test cases? What would happen in terms of the effect estimates if we could apply a new user cohort design to all of our positive controls and all of our negative controls? What kind of estimates would we observe? And so what I'm going to do is I'm going to walk you through some of the results of what we observed when we applied this design and other alternative designs to all of our test cases. So just a reminder, Mark showed you you've got one of the handouts that gives you all of your test cases, but effectively the idea was, well, if Smith et al. Can do a study of isoniazid in liver injury, we'll do the other 398 studies using that same exact design, focused on all the other positive and negative controls, not just for liver injury, but also for acute myocardial infarction, acute renal failure, and GI bleed. And so isoniazid being one of our positive controls, we saw the effect estimate was a relative risk of 4, highly statistically significant. The thought experiment we wanted to go through as well, are there going to be other estimates that are even more substantially different from the null than that? And are those going to in fact be our positive controls, those effects we expected to see, versus the negative controls for which we'd hope that a method like that would not identify? And so once we applied, again, just as a thought experiment, we applied that new user propensity score model to all 399 test cases just to see how the estimates shake out. there's how the estimates shook out. Basically, what I just orient you again to this picture, what I'm plotting here is applying that same study design, new user cohort design using propensity score adjustment, to all of the 399 test cases. The x-axis here is the relative risk estimate, and every row basically represented on the y-axis are the 399. There's basically 399 rows there representing those estimates. And just to kind of give you a cheat sheet here, you got the red ones, those were our 165 positive controls. The blue ones are our negative controls. Okay? So where did isoniazid stack up? Well, when we applied that design consistently all here, we can see that the isoniazid effect, a relative risk of 4.04, that was actually pretty far on the extreme. That was one of the larger estimates that we could observe across our 400 example studies. However, there was a handful of positive controls that had even larger relative risks. Well, that might be reasonable. There might be larger effects than isoniazid in liver injury that do manifest themselves in the data, and here was a handful that were identified using that same design. On the flip side, though, we also identified 5 negative controls that had larger effects. And these, again, were drug outcome pairs for which we did not expect that there was evidence to suggest a true causal association. And in particular, that first one, it should be noted there, GI bleed in simethicone. I don't think most of us think that Alka-Seltzers cause GI bleeding, but this is just a typical example of standard confounding by indication, where those that are taking simethicone probably are taking it for a reason that might be the reason why we would see the co-occurrence of a GI bleed in their record. Now, most of those of us that are practicing epidemiology, we'd probably just be able to figure that out and identify it and kind of explain that away without any issue. The question that we were focused on instead, though, was, well, we'd really like analysis methods and data that would allow us to tease that out for us. So the question we're trying to understand is, why is it then when we did a new user cohort design with propensity score adjustment for all these variables, that when we studied simethicone, we still generated a very large elevated risk for a GI bleed? And in particular, we're trying to understand how often would this occur if we were to use such a tool like this as part of a risk identification system. So again, this is 399 test cases, and it's kind of a pretty busy picture in keeping with the OMOP tradition. But effectively what we wanted to do here was try to develop quantitative ways for us to evaluate the performance of these methods so that we would have a mechanism and a benchmark to be able to compare performance. And one way to do that is to use a receiver operating characteristic curve. Just curious, raise of hands, how many people are pretty familiar with an ROC curve? Excellent, that's awesome. Okay, so that's the most agreement we've gotten in the group thus far. Okay, so we've got a receiver operating characteristic curve, so I won't belabor the point, except to say what we could do with our 399 test cases is we could rank order them based on some metric. We could use the relative risk, for example, such that number 1 in the list is the biggest relative risk and number 399 is the smallest relative risk. And you could then use that rank ordering as a mechanism to measure performance. And so specifically, what we're showing on this plot here is, on the y-axis, I'm showing you sensitivity, or the proportion of the positive controls that we could identify. And on the x-axis, I'm showing you 1 minus specificity. So specificity would be the proportion of the negative controls that were identified. And basically, every point on this graph represents a particular relative risk threshold for which you can just read off the sensitivity and specificity at that threshold. So for example, we could just decide everything's got to be as big as isoniazid. That could be our threshold. And if we did that, we would be setting a threshold of a relative risk of 4.04. And we can read right off of this graph that the consequence of making that decision threshold would be that the sensitivity would be 4%. We could find 4% of true effects. And the specificity would be 98%. So we would only identify 2% of the negative controls falsely. And so we probably would be kind of okay with that specificity, but we sure would like to get our sensitivity potentially a little bit higher than that. Now, one nice trick about an ROC curve is that if we take the area under that curve, that gives us one number to talk about predictive accuracy. And that number we can refer to as an AUC, or an area under that ROC curve. And basically, we're going to talk a little bit about these numbers throughout the day, but just to orient you, think about this is just a big square. We're drawing the area. If we took the area under the diagonal line, that would be an AUC of 0.5. Half the area is filled out. And that would be the equivalent of random guessing. Okay, so that would just be an uninformative system. What we want, what we're all aspiring to together, is to develop something that's perfectly predictive, which would fill up this entire area and give us an AUC of 1. Our findings on this particular new user cohort design using propensity score stratification on the Medicare data across all 399 test cases, this gave us an AUC of 0.64. Much, much better than random guessing, kind of far away from a perfectly predictive model. So, but it's actually, it can be difficult to think about these numbers in absolute context. So 0.64, is that like I just took a test in high school and I just got a D- or something like that? Or am I really aspiring for 100? Well, as many of you are familiar, we use diagnostic tests all the time in clinical practice. Many of these diagnostics have been measured in terms of their predictive accuracy using AUC, and generally, just order of magnitude ballpark, the types of tools that are out there in use in clinical practice usually have AUCs ranging somewhere in the 0.6 range up to somewhere in the low 0.8s. Okay? It's really hard to be able to predict disease for individuals, and as a result, we need to be able to think about not having an expectation that we're going to be able to build a perfectly predictive model, but instead try to develop a model that's pretty reliable in helping us understand the effects. Okay, so you can see already if we could stop here, and if people want to, you can leave and just say the new user cohort design is the solution, because we're as good as a PSA test, and we could. Mostly men laughing there, so I'm not sure if that's funny or sad. What we've really been seeking to do is to think about, okay, well, that's how well this particular method could work. But two things. First, how does the performance of other methods and other design decisions work for the same exact set of 399 test cases? And also, what other strategies could we apply so that we can collectively raise the tide of performance and improve the predictive accuracy? So I'm just going to point out how to interpret these ROC curves. Again, you've got all the slides. We know it's risky business giving you an internet connection, but hopefully most of you aren't surfing the web, but just looking at our slides. But part of what we're giving you here is we're going to give you some tools to think about how to make decisions about what's good enough and how you might want to think about setting thresholds for making decisions. So for example, we could say, well, I'm going to use the tool to find things that are the doubling of a risk. And we could set the threshold at a relative risk of 2. And you can read right off on the graph here, we could say, well, if the threshold is 2, then the consequence would be using this method against the Medicare data, we would achieve a sensitivity of 26%. That is, we could find 26% of the positive controls. And that would cost us an expense of a 10% false positive rate. So one way we could do things is set a relative risk threshold and then look at the sensitivity and specificity. We could also turn this on its head and say, well, we really want to have a risk identification system that's at least finding us half the true effects that are out there. I mean, maybe we can't find everything, but we could at least find half of the things. Then you could ask yourself, what would the threshold need to be in order to achieve identifying half of the true effects? And you can see this method, we would need to apply a threshold of a relative risk of 1.25, and the consequence would be that our specificity is 69%. Now, some folks might say, well, geez, I'm really worried about false positives. I don't have the resource, and I'm concerned about having false alarms too often. Maybe what we need to do is we need to set our threshold based on specificity, and we could say, I want to experience no more than a 5% false positive rate. In which case, once again, you can use this ROC curve as a decision tool to read off and to see, if you say, I want to have a 5% false positive rate, no more than a 5% false positive rate, then you should make a decision to set your threshold at relative risk of 2.8, and that will produce a consequence of allowing you to identify 10% of the true effects. I am not going to tell you what you should set your threshold at, but we are trying to provide you tools so that you can start to think about how you want to balance the risks of false positives and false negatives and understand the performance. Ultimately, our goal would be to have a perfectly predictive system. Then we don't really need to worry about this problem so much. But as long as we don't have that perfect prediction, we're ultimately always going to have a decision to make about what threshold to set. And I would contend that ultimately that's a decision that all of you need to make as stakeholders to think about the information you'd like to see. Okay, so cohort method, Medicare data gives us an AUC of 0.64. 0.64 is much better than random guessing. This is not uninformative data, and it's actually kind of consistent with some of the diagnostics that have been used. But at most of these thresholds, one could argue that we have a kind of an unsatisfactory rate of false positives and false negatives. And so the question that we've been seeking out to think about is what strategies can be applied to these data, whether it be analytic strategies or just ways of thinking about interpreting the data that can make us have even better predictive accuracy. And so I'm going to walk you through actually 4 different ideas that we've come up with and evaluated, and actually each one of these seem to really start to improve the game. And so I'm excited that together what we can share today is performance that we think really is a real step forward from some of the results that I've seen in the literature and that OMOP has presented up to this point. So idea number 1, we want to build a risk identification system. We want to study all possible drugs and all possible outcomes. If we think about what we're doing in spontaneous adverse event reporting data, some of us are applying data mining algorithms, and effectively the idea is you apply an algorithm, you take Bill's MGPS method, you apply it to all drug outcome pairs, you set some threshold, you say the EBO5 is greater than 2 because Anna published it and said that we should. And then based on that, we say everything above that threshold is a signal. That's perfectly reasonable, and that's actually kind of the starting point that we came from, and that I think a lot of people were hoping we could use in such a system. But one of the insights that we had going into this is, well, if we're focused on different types of outcomes, and different types of outcomes have different types of bias and confounding that exist in the data, maybe we shouldn't strive to build a risk identification system that's a one-size-fits-all. Maybe instead we should ask a slightly different question. What's the best risk identification system we can build for acute myocardial infarction? And separately, what's the best risk identification system we can build for acute liver injury? What's the best risk identification system we can build for GI bleed? If we, instead of thinking of all drug outcome pairs as just in one giant pot, if we instead ask the question, why don't we split up our results by outcome, maybe we're able to make more logical head-to-head comparisons. When we get a relative risk for some drug with MI, we'd like to compare it to the relative risk for some other drug with MI, rather than comparing acute isoniazid liver injury with ibuprofen and renal failure. And so just as you wouldn't expect someone to apply the same diagnostic test to study all different diseases, so too it gives us an opportunity to think about maybe we could evaluate the performance of a risk identification system across outcomes. And so all we did was we took our 399 test cases and we dumped them into the 4 buckets of the HOIs that we were studying. And when we did that, we observed something quite interesting. Up top here, I'm showing you that same ROC curve, but now just focused on acute kidney injury. And if I just focus on the positives and the negative controls for acute kidney injury, I can achieve an AUC of 0.67. So again, new user cohort design, propensity score on Medicare data. If we only use it for acute kidney injury, we can get an AUC of 0.67, actually slightly better than the overall. If we just apply it for acute liver injury, we get an AUC of 0.61. And there's your isoniazid. So now you actually can see for liver injury, we can actually achieve a slightly higher sensitivity at still a probably acceptable specificity. That is, now you've made isoniazid more comparable with other drugs because you're focusing on that particular outcome. For acute myocardial infarction, we could observe an AUC of 0.66. And for GI bleed, we actually got all the way up to an AUC of 0.71. So just to put that together, we can see just by splitting up how we interpret the results and focusing on one outcome at a time, what we observe is that this same method actually performs differently for different outcomes. In fact, it looks like a risk identification, if we want to use a new user cohort design, a risk identification system for GI bleed might actually be more effective and more predictive than a risk identification system for acute liver injury. Does that seem to make sense to most people? See some heads nodding up and down and a couple nodding left and right. I'm going to hope for more up and down than left and right, I think. And I think to a certain extent, I think we all kind of have this gestalt that says observational data will work better for different outcomes. And one of the things we were excited to see is that now we're starting to get some empirical evidence to bear out that actually suggests exactly what are the situations where the system might work better, and similarly, what are the situations where we probably need to be a little bit more hesitant in our interpretation. Okay, but again, all I've done here is this is just practically a magic trick. I just took the 399 test cases, split them into 4 buckets. I didn't change anything about the analysis method. So question: if actually, let me walk through this so that again, just to focus on this. So now we could ask the question for each of these 4 ROC curves. Let me set a threshold of relative risk of 2. And we can evaluate the sensitivity and the specificity. And what you notice is that the sensitivity, using the same exact threshold, the sensitivity is actually different across the 4 outcomes. Kidney injury and liver injury, a threshold of 2 will actually find you about 1/3 of the effects, the positive controls. Whereas a relative risk of 2 will only find you 13% of the positive controls for GI bleed. So again, not only do the system perform differently, but in fact you might make different decision rules for interpreting the results. And I think to a certain extent this might make sense. We don't necessarily expect that drugs have giant effects for acute myocardial infarction, particularly given the high background rate. But in contrast, potentially given the low frequency of liver injury, maybe we would expect that in the idiosyncratic nature of it, maybe we would expect to be able to set a higher threshold to identify potential effects. Again, we don't need to set our threshold based on the relative risk. If you want to set it based on specificity, you have the opportunity there to say, well, I don't want to tolerate more than a 5% false positive rate. Now you can see what relative risk thresholds you would actually need to observe and the consequence of the sensitivity. So actually with GI bleed, what we observed is we can say we don't want to have a high false positive rate. However, some of the estimates were at the top end of that list. In fact, the majority of those were negative controls, and as a result, we wouldn't be able to identify too many positive controls using this new user cohort design in this context. We might want to set our threshold at, again, saying, I want to find half of the true effects. I want a sensitivity of 50%, in which case you can see here the thresholds and the specificities that come along with that. Again, I'm not making any assertions of what threshold you might want to set, but just trying to give you a sense of how you can evaluate the trade-offs in the evidence that we've been generating. Okay, so now that we've split up things, we've said, let's not build a system that takes all drug outcome pairs and mixes them all together. Let's instead ask the question, what's the best analysis that I can perform for acute myocardial infarction? What's the risk identification system performance for liver injury? Well, one thing we could do is if we're tailoring, if we're going to build a different system for MI than liver injury, why do we have to use the same method? Why couldn't we choose different methods for different outcomes? In fact, this is what we do all the time when we're doing a one-off epi study. We think about the outcome of interest, and we think about what's that right study design that Paul went through to make that choice. Now, one way of thinking about this, if we were to do custom observational studies, we would probably take a particular drug and a particular outcome, and we would design a custom study to answer exactly that particular effect. Now, if we're going to build a risk identification system for acute myocardial infarction, we don't necessarily have the luxury of custom designing the study for each and every drug that's going to be in that risk identification system. But maybe we could learn from all the drugs that are used to study acute myocardial infarction, and we could select a method that could be consistently applied to all drugs when focused on building that risk identification system for acute myocardial infarction. And so what we wanted to look at was trying to understand how well could we perform if we look at different methods, and which methods would those in fact be. Now, this question about, is it even possible for us to make a choice of choosing one analysis and applying it consistently across all drugs for a given outcome? Well, here we can go back and lean on our results from the Eddy survey to see what the experts actually did. And when we looked at, when experts were asked the question, for acute kidney injury, what do you want to do for the first drug? What do you want to do for the second drug? What do you want to do for the third drug? What we found was, generally consistently across all the outcomes, the majority of respondents generally chose the same design for multiple drugs when studying the same outcome. And I think that actually, there might be subtleties within that design, but at a conceptual level, if you like a cohort design for MI for a particular drug, you probably like a cohort design for MI for some other drug. What we observe, though, is that this result's pretty consistent with what we see in the literature. Paul pulled up those papers, and what you noticed when he was pulling up those papers was that they applied one study design. They applied the case control design, and then they looked at a lot of different drugs in that same design to estimate the effect. And we saw this in all of those papers that Paul pulled up, that they didn't just look at isoniazid and liver injury. They actually said, we're studying hepatic issues, and we'll apply one study design to the data, and we'll report out the effect estimates across multiple drugs. And we saw that consistently in the literature. So I'm not saying that this is the right solution, but we feel pretty comfortable making this compromise to say, if we're going to build a risk identification system for myocardial infarction, it might be reasonable for us to start by picking one study design that seems to work generally well across those pairs. Okay, so the hard part now, how do we pick the study design to actually use in this context? And so one option would be we could use expert judgment. We could sit down and we could say, okay, I'm about to study acute myocardial infarction. Let's design the analysis that reflects all of our clinical knowledge and epidemiologic expertise pertinent to that particular situation. And that's perfectly reasonable. It's what we do for every custom epidemiologic study. And the only challenge we have is twofold. One is we've got to figure out a place to get all of that clinical knowledge and epidemiologic expertise. And then we need to know the degree to which it's consistent, the degree to which those experts agree. And as I showed you earlier with the Eddy survey, what we observed from our community was that in fact there's a wide-ranging perspectives in the community about the appropriate practice and which methods should be applied to which situation. An alternative approach, not better or worse, but just an alternative approach, and what we're going to focus on today is a more empirical, data-driven idea. The idea would be, rather than us picking a method and hoping that it works well, what we could do is we could apply all methods and we could optimize performance. We could select the method that achieves the best predictive accuracy. So for example, we've just been describing AUCs, and if our goal, if our shared goal of a risk identification system is to be able to find the positive controls and discriminate them from the negative controls, wouldn't we like to have a system that actually does that best? What we've been focused on within the OMOP experiment is to be able to try to apply all methods to our data for all of these 399 test cases, and then try to identify the particular method that we can consider best on the basis of having that highest predictive accuracy. Now, of course, how do you know that just because it worked for our 399 test cases, how do we know it's best for your particular question? Again, challenges remain. What we're going to show you is the results of what happens if we do apply this empirical, data-driven approach. And so here's one step in that direction. I'm showing you those same trellis plot of 4 ROC curves, again split out by outcome, so kidney injury, liver injury, GI bleed, and acute myocardial infarction. But you notice the AUCs are now a little bit higher. For kidney injury, we're now up at a 0.73. For liver injury, we're up at a 0.72. Myocardial infarction, we've jumped up to be able to be 0.75. GI bleed, we're already up to a 0.85. Okay. Remember that slide I showed of the diagnostic test where we basically said things that are in practice right now somewhere between a 0.6 and a 0.8. So we're about a 0.6, and now you can see by choosing a different method for each different outcome, we're actually starting to see very promising performance. What was a big insight for us, and actually quite surprising and made us scratch our heads for quite some time, is when Paul showed you all of those study designs, we went ahead and applied them all. Kind of expecting what you all expected. That new user cohort design, it should probably just float to the top. And instead we saw something quite interesting. In fact, self-controlled cohort designs consistently performed best across all 4 of these outcomes. And in particular, what I'm highlighting there for you is the particular method, so this is observational screening, and the particular parameter choices that were necessary for acute kidney injury. And what you'll notice is that observational screening, the self-controlled cohort design, comparing the post-exposure time with the pre-exposure time, that method, some variant of that method, actually performed quite well for acute kidney injury, performed well for liver injury, and performed well for acute myocardial infarction. And what we observed empirically was the best performing method for GI bleed on the Medicare data was in fact the temporal pattern discovery method, which again was a very similar variant of this self-controlled cohort design. So we were pretty struck with this, that what we could observe is, first, just by making the decision, we're going to pick different methods for different outcomes. You notice that it's the same family of designs that were selected, but in fact the specific choices, all those design decisions that Paul was talking about, they're actually different for all different outcomes. And I think that makes sense, that that's consistent with how we think about doing epi studies, that we want to custom craft and tune each study. Well, in fact, what we observed is that really can achieve better performance. So my guess is that you probably are wondering, what the heck was 402002? Well, we're going to at least give you a little bit of extra information about that. Just to give you a sense here, those coded numbers there, they basically reflect the various choices that go into the design. So for kidney injury, that self-controlled cohort design, the optimal parameters, the choices that led to the highest predictive accuracy was to use all exposures available in the database, to use all outcomes, to define our surveillance window as the length of exposure plus 30 days, to use that same window prior to exposure to make your pre versus post comparison, and to include events that occur on day 0 in both groups. So you basically, when an event happens on day 0, you don't really know, was it the drug that causes the event, or did the event cause the person to go get the drug? And so in this particular choice, it actually was counted in both buckets since we weren't quite sure. Now, this self-controlled cohort design, again, what we observed in terms of the optimal performance here, was that general family of designs was consistent across our 4 outcomes. However, some of the specific choices that were made within a particular algorithm were slightly different. Okay, so what happens now if we ask the question, let's set our threshold a relative risk of 2, what kind of performance can we achieve? And what you see is now we're getting remarkably different performance across our 4 different outcomes. If we make the choice to say, I'm only going to look at things with a relative risk greater than 2, well, for kidney injury, we're going to now be able to find 71% of the positive controls. However, that's going to come at a consequence of about a 73% specificity. So we're going to end up finding 27% of the negative controls as a consequence. But look at liver injury, for example. If we set our relative risk threshold at 2, we'll be able to find a quarter of the positive controls, not a single negative control. We've basically eliminated the false positive findings for liver injury when applying this particular observational screening design to the Medicare data. But we'd like to get that sensitivity up potentially even a little bit higher. But on the flip side, you've got GI bleed, and in the context of GI bleed, setting a threshold of 2, it gives us pretty impressive specificity, but we're not necessarily finding as many effects as what we would otherwise like. Again, I'm not saying that setting a threshold of 2 is the magic number. You might say, well, I'm going to use a threshold of 50%, a 50% sensitivity, in which case you can see here how the thresholds vary, and certainly how the specificity would vary by using those thresholds. And I think that the main thing to focus on here is that by customizing the analysis and tailoring to the particular outcome, we can make different study design choices, and those different study design choices start to really get us to more promising results, something that we might be able to take home and use. But we weren't really satisfied stopping there. We wanted to see, well, can we squeeze more orange, more juice out of this orange? And one thing we did was we looked to our epidemiology colleagues and, well, what do we do when we design a custom study? And one thing we often do is we first ask the question, well, is there even enough data in the database to allow us to answer the question in the first place? And of course, if we're thinking about a risk identification system, we'd like to study all medical products. But attention, of course, we've got is some medical products are blockbuster drugs with hundreds of thousands or millions of exposures. And some drugs are orphan products that may not even be on your formulary and might only be in the database in a handful of folks. And similarly, the rates of prevalence of adverse events varies considerably. There's a big difference between us asking the question of studying a newly marketed product, which we don't have very much exposure for, versus a mature product that's been on the market for many years. And similarly, there's a very big difference between studying any old anti-diabetic and some new product, which might not even make it onto the formulary. And so if we were to do a custom one-off study, we'd probably check the data and ask, do we in fact have enough data to begin to answer this question? And one thing we could think about is borrowing that idea from epidemiology is in a context of a risk identification system, maybe our goal shouldn't be to study all marketed products. Maybe our goal should be to study all marketed products that we've at least got a chance of studying. That is, that we have enough data to be able to explore. And so to play with this idea, what we did was we looked at the prevalence of the medical products in our databases, and we're able to basically use a standard power calculation to basically say, do we have enough data to be able to detect the types of effects we want to? And by restricting our 399 test cases to only those drug outcome pairs for which the database does present enough evidence, can we in fact further improve our performance? I think it's probably old hat to many of you, but we can think about determining a sufficient sample by doing a standard power calculation. In our context, what I'm going to talk about for the next couple of minutes is the idea of, instead of saying I want to achieve 80% power and using that to figure out how much data you have, we've actually got the opposite problem. The data has already been handed to us, so we need to instead ask the question, what kind of effect size can I observe given the amount of data we have? And of course, this has been around forever, how we can calculate a minimum detectable relative risk. That becomes basically your surrogate for how much data you have, and we can then ask the question, can we set some sort of thresholds to decide how that would look to work? So here's where we started. Here was all of our test cases, 399 test cases, partitioned by the 4 outcomes, tailored analyses to try to get that performance. And this is what you were just seeing before. And you can see how many positive and negative controls are in there. So we went through the thought experiment and say, okay, what if we restrict ourselves to those that we have enough data to detect a relative risk of 4 or greater? So let me go back. This is where we are to start with. Here's where we were able to achieve. I'm going to probably give somebody in here an epileptic fit, but I'm going to keep flipping back here so you can start to see performance. You can see for kidney injury up in the top left, we were at a 0.73. Just by eliminating the test cases that we didn't have very much data for, you can see we only eliminated 2 positive controls and 1 negative control, but those actually influenced our performance pretty substantially. Now, a relative risk of 4, that's a pretty big effect. We don't actually expect most of the effects to get there. So let's throttle that back. Let's say, what if we need enough data to find a relative risk of 2? What if we need to have enough data to be able to identify a 50% increase in risk? Well, in fact, we probably, if it's enough evidence to remove a drug from a market to have a relative risk of 1.41, we probably want to have enough power to detect something that's at least a relative risk of 1.25 anyway. And what you can see that's quite remarkable and kind of was one of those things where it just slammed you in the middle of the forehead when we saw it was, yeah, sure enough, if you restrict yourself to questions that you got enough data, you can actually perform quite well. And we were really excited to see this type of performance here. You can see with kidney injury, we've now got an AUC of 0.92. For liver injury, we're at a 0.76. Myocardial infarction, we're able to have a predictive accuracy of 84%, and GI bleed, we're up to 86%. Now, of course, this comes at a consequence. We made a choice here, which is to say we're only going to study things that we have enough data for. That means there aren't as many questions that we can use a system for. But for the questions we've got enough data, we're really at a pretty impressive level of performance here. Remember those clinical diagnostics I went back to, good practice somewhere between a 0.6 and a 0.8. We're basically at or beating some of the diagnostics that are out there being used. But again, what it required us to do was to partition our results, to tailor the analysis to the outcome, and to restrict on sample size. And when we applied those strategies all together, that's what started to get us to improve the performance that we were observing. Okay, so this gives you your side-by-side, the little teeny dots, just to make it even more of an eyesore. That's basically where we started if you don't restrict your sample size. In those big dots, that's where we got to by restricting our sample. So this graph's trying to give you a sense of how much improvement we saw in the AUC, how much improvement we saw in predictive accuracy, and also what was the consequence, how many test cases would we basically lose. Now, again, this is not saying that the relative risk of 1.25 is a magic number. This represents a trade-off. If we want to be able to explore more outcomes, we're probably going to have slightly less predictive accuracy. If we want to have a system that we have more reliability, we might want to make a choice to say, maybe some of those questions we should really hold off until we have enough data. I don't think this is any different than what we do with an epidemiology study. We probably wouldn't do a one-off study if we didn't have enough data. But I think it is, at least for me, it was a bit of a mind shift to think about a risk identification system. We really like to study all drugs and all outcomes. Maybe a reasonable approach would be to focus on those for which the data is more fruitful. Okay, so again, we've applied all of these rules. We've applied partitioning, tailoring, and restriction. And again, now we can ask the question, well, what kind of performance do you see if we have a sensitivity of 50%? And now what you see is we've got pretty different thresholds. For kidney injury, we can say, set your threshold at a relative risk of 2.7, and that will achieve you a specificity of 95%. We've now gotten ourselves down to only having 5% false positives, and yet we can find half of the positive controls that we were looking for. And now we actually have some sort of a basis to know what kind of threshold we would want to apply to these data. And what we notice is that's very different. For liver injury, I'm not going to use that same threshold. For liver injury, our empirical experiments suggest that we should set a threshold of 1.5. That will achieve about a 10% false positive rate, but it'll allow us to identify half of those positive controls. Okay, so just to recap where we've been and where we're going here. Before, what we started with, we used a new user cohort design, propensity score stratification, applied it to all test cases. Seemed like a reasonable starting point. Certainly I thought it was. And what we observed was an AUC of 0.64. And if we said we want to achieve 50% specificity, sensitivity, you would have had to choose to set your threshold at 1.25. The consequence of setting that threshold would be that you would have specificity of 69%. As we applied these rules, we started to see incremental improvement in performance, and after applying partitioning, tailoring, and restriction, what we observed is the AUCs are now all in the range of from 0.76 to 0.92, and the thresholds are very different, but if we want to achieve a sensitivity of 50%, now we're in a specificity range where the false positives are much less than where we were before. So I certainly don't think in any regards this is the last word, but we, at least the OMOP team, we're quite encouraged by feeling like these seem like practical recommendations that could be applied and that do seem to actually yield more promising results. What's also important to note, though, is despite the fact that we've applied the results, we're still not in the situation of having a perfect risk identification system yet. Again, we'd like to have these AUCs up at 1, but we're starting to get to the point that maybe if we can put ourselves in the right perspective, this information can be informative, although not be definitive. So again, going back to what Melissa and Rachel and Janet have been saying all along about the Sentinel system, Sentinel is just one piece of evidence to put in conjunction with everything else. I think the OMOP empirical results actually really lend a lot of credence to that. This looks like it can be quite a useful piece of evidence that can be pretty predictive if we think about applying a risk identification system following some pretty basic recommendations. However, such a system is not going to generate the final word and should not be treated as a definitive piece of information to make any sort of assertions about what a true effect might be. Okay, everything I just told you was the Medicare database. So I just told you one database, but you remember Mark gave you a handout and says we had 5 databases that we were looking at. One more idea. So, okay, we just applied to the Medicare database our 3 recommendations. Question is, what should we do across other databases? And one thing we could do, and actually it's kind of, at least for me, seems kind of straightforward, is I guess we should just pick one method and apply it consistently across all databases. And that's actually what we looked at and what we observed. And then David had the insight. He said, well, if the databases are different, they represent different source populations, they represent different mechanisms of data capture, they represent different periods of longitudinality, they represent different disease severity. If the databases are so different, why are we picking the same method for different databases? And so one of the things that we explored was we asked the question, well, what I just showed you for Medicare, we optimized the method to the database. Why don't we just optimize the method to each database and ask the question, which method works best for which database? And this might actually make sense if I held up the GPRD database and said, what do you want to do? And then I held up the Thomson commercial claims database and said, what do you want to do? You might not make the same choices. And so we just tried to, again, provide some empirical data-driven evidence to suggest that, in fact, yes, we might be able to actually improve performance even further if we optimize the analysis to the data that we have here. So again, you've got a handout that's telling you about the databases. Just to remind you, what I'm focused on discussing right now is 5 different databases, the GE centricity data and the 4 administrative claims databases from what was Thomson Reuters, the market scan databases. So first things first is, well, remember our third recommendation there was we want to restrict on sample size. Well, a consequence of that, of course, is sample size is a function of your database, which means different databases are going to be able to allow you to answer different questions. And rather than applying a method blindly to all test cases, we might want to understand which databases have enough data for a particular question. And I won't belabor the point on this graph other than to say on the x-axis, I'm showing you that minimum detectable relative risk, and the colored lines are just showing you how many test cases each database could cover. So for example, for kidney injury, what we observed is the MSLR database and the GE database imposing the sample size restriction really reduced the number of test cases that we could study, so those databases wouldn't be able to be used for as many questions. Whereas in contrast for GI bleed, most of the databases were able to study the majority of the test cases even after imposing that restriction. All that is to say is that if we're going to study different drug outcome pairs in different databases, we need to understand what the baseline data characteristics are and to be able to identify which databases could answer a particular question of interest. Okay, so optimal methods. So what I'm showing you here is, let's see, trying to be color coordinated for y'all. You got a blue handout. The blue handout is going to give you a grid which shows you in the columns are 4 outcomes, and in the rows are 5 databases. And what I'm showing you on the slide right here is the predictive accuracy that we were able to achieve by applying these same practical rules by tailoring, by partitioning the outcomes, tailoring the analysis to the outcome, restricting on sample size, and optimizing on database. And what you can see is, by and large, across our 4 outcomes and across our 5 databases, we were able to achieve pretty strong predictive accuracy across the board, generally in the range of the high 0.7s all the way up to the 0.9s. When we looked at which family of study designs carried the day in terms of being the optimal choice, what we observed was something quite interesting. We saw in a lot of contexts that self-controlled cohort design within the observational screening method actually was the optimal choice. There were a few situations where using self-controlled case series methodology was best. And there was a couple situations where the temporal pattern discovery algorithm actually led to the highest AUC. Now, what those 3 designs have in common, they're all focusing on this notion of self-control. Rather than using external referent group, which is what a case control design and a cohort design do, these designs are relying on using pre-exposure time within the individuals of interest. As Paul mentioned, you know, the active discussion at ISPE, you know, the self-controlled designs in general have been kind of the sexy new kid on the street of the methodology street here. But what we're starting to do is look at evidence that suggests, you know, typically we've been thinking about these designs as having a fit for purpose in very narrow areas. And yet what we've been able to observe empirically is that in fact they seem to perform quite well across a wide array of different data and different outcomes. Now, to make your life just a little bit more complicated, we've got the challenge that if you'd really like to have a one-size-fits-all solution, that means you want to pick one method and one set of study design choices and to apply that consistently. And yet these little numbers represent the particular permutation of that method we applied. The specifics of that number, that's what's on your blue handout, so you can actually read that at your leisure. But what I want to point your attention to is if we wanted to have a one-size-fits-all solution, you'd like to see that number consistently across the screen. In case you're looking for it, you're not going to find it. In fact, what we observed is that consistently across these situations, different design choices, even within the same methodology, different design choices led to the best performance that we observed in terms of predictive accuracy. And what that suggests is that you really do want to at least think about how you could systematically tailor analyses, because some of these design choices, they might work well in one database, they might work well for one outcome, but they might not, in fact, be the best choice that you could possibly make across a range of different outcomes in different databases. The other thing that was pretty interesting as we started to explore this is many of us went in with a bit of a preconceived notion that I got these 5 databases, but there's maybe some of them aren't as good as others. Maybe we don't expect them all to perform the same well. What I can tell you right now is at least what we've observed, despite the fact that we all have some preconceived notions about which database is best, we've got no empirical evidence to support the assertion that any one of these 5 databases is better or any one of these 5 databases is worse than each other. Instead, what we observed is you have to make different choices to make different databases perform well. And that was a big eye-opener for us that we're still wrestling with. The other thing that we observed is for kidney injury, MI and GI bleed, we generally see consistently pretty strong performance across all 5 databases, and we saw consistently liver injury seem to perform just a shade below. Any of you that have done a study of hepatic issues know that that's a pretty thorny issue, and so I don't think it necessarily comes as a complete shock that we would expect that to be potentially a little bit more difficult to wrestle with. All right. So, where did my phone go? There's my phone. Okay. So, now I've got still some time left, and I want to ask you guys to participate in the game here. So, what I just described for you, I gave you performance of all the different methods, or we looked at these different design choices across all the databases and all the methods. And I've tried to sell you on the idea that I think the performance is pretty impressive. Certainly a pretty big step forward from where we are before. But we've had active discussions amongst our executive board about, well, good is in the eye of the beer holder. And we might be in a situation of saying, well, is this really good? Is this actually what we need? And ultimately, this comes down to the sense that it really depends on your tolerance, your personal tolerance for false positives and false negatives. I can't tell you what threshold to choose. I can't tell you what method to choose. But what we can do, and what OMOP has tried to do, is provide the community with the tools and the empiric evidence to support this. To make this a little bit easier for you, one of the things we have developed is a web-based tool, which I'm going to invite you all to play with. It's called Elmo. Elmo, you can actually, if you've got your Droid or your iPad or your laptop, you can just log into it online at elmo.omop.org, or you can take a little screenshot of the QR code up there, and it'll bring you right to the website. I'm really hoping people do that because Erica had to teach me how to figure out how to make that work. So someone needs to take a picture just to make me feel better. What I want to do is I'm just going to show you real quickly how you can play with this during the break to give you a sense of it. What Elmo is just a little web page, and you're going to get to make the choices you would like. You can pick your database, so we'll pick the CCAE database. Pick one of your 4 outcomes that we're studying, so you could look at acute myocardial infarction, and then you'll be able to get access to what is the source optimal method. And if you want to know what that source optimal is, you could just click on the method name. It's going to tell you all of the settings that are on your handout. But maybe you say, well, I don't really like observational screening so much. I want to choose a self-controlled case series design, in which case you choose that design. What you're going to have immediate access to is that ROC curve. Well, what are you going to do with an ROC curve? Well, the ROC curve is going to tell you how predictively accurate that model is, and you get to play the game of setting the threshold you'd like. If you set your threshold, what you can read right off of this graph is I set my threshold at any particular level. If I say my threshold is 0.97, the consequence of that choice is that my specificity will be 28%, my sensitivity will be 91%. Maybe you don't want to have that many false positives, maybe you'll throttle it back. Again, you'll be able to play the game of trying to make a decision for yourself where this ought to be. Now, this is a kind of a fun tool. You can all play with ELMO. Practical reality is we want to use this tool for risk identification. So the question is, for the FDA, for pharmaceutical industry, for academia, if we actually said, okay, maybe we buy what OMOP's selling here, and we want to apply this tool, what is it actually going to do as a society? How many signals are we going to be generating? And what's the frequency of those false positives and false negatives? By making your own choice about what threshold you specify, and making a decision, how many drugs do you want to study? You can say, well, in this case, I'll say, I want to study 500 drugs, and I want to look at, and I'm going to assume that in the background, 5% of drugs actually cause, what did I select? We're going to assume in this case 5% of drugs are likely to cause acute myocardial infarction. If that's the case, and I specify my threshold at 1.07, the consequence of that is that you would find 11 positive controls. That is, those would be your true positives. That's going to come at a consequence of failing to identify 14 effects and generating 41 false positives. If I set up my threshold a little bit higher, here's a threshold I can set that'll allow me to identify 4 effects, minimize my false positive findings, but as a consequence generate additional false negatives. Again, we're not here to tell you what method you should choose, what threshold you should set, but what we are trying to do is, as a community, make this information available so that you can have some empirical data-driven evidence to support the decisions that you might be making in your future. So with that, I'm going to stop. I'm going to give you about 15 minutes here to play with ELMO, or for those of you that really can't take it, you can go get a break. I think we're going to come back at 10:45, and we're going to continue to talk about some of the insights we've observed. Thank you.